My name is Fred Hirsch. I'm a medical oncologist. I'm also trained in pathology. I was trained in Copenhagen, Denmark. I am focused on lung cancer. I moved to United States in 2000, University of Colorado, was there for 18 years. As a professor at the university there, working on lung cancer research, translational research, with a focus on new biomarkers for new therapies in lung cancer. Beyond that, I was 5 years also the CEO of the World Lung Cancer Organization, ISLC, International Association for Study of Lung Cancer. And in 2018, I moved to New York, and I'm a director of the thoracic oncology program here at Mount Sinai, New York. I'm excited about everything which has happened over the last, I will say, 20 years, starting with molecular targeted therapies for advanced non-small cell lung cancer, exemplified in the beginning with EGFR targeted therapies, ALK targeted therapies. It moved quickly to other specific targeted therapies as well. Today we have ROS, RET, NTRK, MET, you name it. We have many different targets and many treatment options, often several treatment options within each target. So that is certainly something which has been very exciting over the last 10, 15 years. Most recently, I will say I'm most excited about treatment of early stage disease, both as neoadjuvant therapies as well as adjuvant therapies. And the development there goes very fast. I foresee in the future, we will see, I will almost say, an explosive development in early stage disease. Also in unresectable stage 3 disease, we see progress. So making a long story short, in the beginning and still there is very remarkable progress for patients with advanced non-small cell lung cancer. Today we have seen a rapid development in therapies for early stage non-small cell lung cancer. I mean, we will continue to see progress both in early stage disease and in late stage disease. There are many combination therapies out there in clinical trials. It's so many that the science often lag behind. It goes so fast that we cannot keep up scientifically with all the combinations out there. We have in the EGFR space, we have a combination with EGFR and VEGF inhibitors, non-oncogenic driver space, combinations with immunotherapy, many combinations with immunotherapy. We have immunotherapy plus immunotherapy, meaning we have PDL1, PD1 inhibitors in combination with CTLA4 inhibitors, with and without chemotherapy. We have PDL1 inhibitors in combination with chemotherapy, which is kind of standard of care for at least for patients with PDL1 expression less than 50%. In some cases, also for patients with high expression of PDL1. Many other combinations out there in clinical trials. Particularly, I will say ESMO this year had a lot of new and game-changing results presented. There were several of them. In the early stage disease, we saw new perioperative studies, Keynote 671, with pembrolizumab and chemotherapy. We saw in ALK space ALINA study with adjuvant alectinib, which was a very large study and significant improvement in outcome with an ALK inhibitor in early stage disease. Particularly at ESMO, I was impressed of the ALK study. In World Lung, we saw FLORA2 with osimertinib in combination with chemotherapy. And that was also a positive study, although with combination comes also toxicity, which which might be a barrier for implementation of FLORA2. We had also updates from Audora study, the EGFR adjuvant study with preliminary survival data and follow-up. I do believe that artificial intelligence will play a significant role, and we see a very rapid development of use of artificial intelligence. My focus has so far been using AI in pathologic assessment after neoadjuvant therapy, but artificial intelligence comes in also in terms of assessment of nodules in lung cancer screening setting. I know there are works going on there, and certainly also when we are talking real-world data for developments in advanced disease, artificial intelligence is the use of large data sets And this development will go very fast, in my opinion. My takeaway is we have seen a very, very encouraging progress in lung cancer management. First, we saw it particularly in patients with advanced disease. What we see these days is a lot of focus has turned into early stage disease. And of course, with lung cancer screening, which needs to be better implemented, but with lung cancer screening, we see on new technologies, we see more early stage disease than we have seen before. Unfortunately, we see today a rapid development in treatment options for patients with early stage disease. As I said, both in the neoadjuvant space, in the adjuvant treatment space, and in the perioperative treatment space, meaning combination of neoadjuvant and adjuvant therapies.